the global virtual morning report. I think that I think the time change has made it such that I think only a smaller and smaller group is able to show up, which makes it interesting. I think it pushes me at least to actually try to present to you all, because I think when it's a small group like this, the goal might be to actually get everybody to say something. So I actually have a case for you all, but I wanted to thank our dear friend Stephen, who's one of our LeCom students who's actually scribing for us today. So thank you, Stephen, and welcome to VMR. There are many goals with this case that I'm going to present to you, but they're all about arming you with fundamentals to help you take care of very common issues. Cool? We'll try to put a global twist on it, and that's going to be a little tricky with this case, but we will. If you are able to share your thoughts, please do so in the chat. And what would be an extra bonus point, of which there is no value to these points, turn your video on, hang out, let's learn together. The more engaged we all are with our videos, the more. Hello, hi Ariel. Do you want to unmute and tell us about yourself? I don't think we've met.
Hi, I am a big fan. I'm not actually a medical student. I'm a veterinary student.
Oh, no way. That's so cool.
Thank you.
Yeah. So wait, tell us more about where you are in your learning.
Okay. I come from China, and I'm a first-year vet student in UC Davis.
Amazing. That's so cool. You're right up north. Yeah. I live in San Francisco. And how does a veterinary medicine student learn of the clinical problem solvers?
Oh, I just came through you guys about like 2 years ago on podcast. I'm like a big fan. I listen to every episode, and I subscribe to RLR.
Oh my God. Well, you know, I can't help but recognize the high ratio of RLR people on this call. It's kind of incredible. I think all of you are pretty committed to learning medicine, which is really cool. It's so nice to meet you. If you're ever in San Francisco, you should definitely shoot me an email. Now that you are on RLR, it'd be wonderful to meet you. How long is vet school?
4 years.
4 years. Okay, cool. If you listen to RLR, you probably hear me talk about my dog all the time. And today I'll finally be able to show you him at some point.
Nice.
Cool. All right. Well, I have a case for you all. And I will just, I see another video turned on. Hi, Stephen. Do you want to unmute yourself and introduce yourself to everybody, if you can?
Yes. Hi, everybody.
Oh, there are two, Stephen. There's Stephen, who we just met. No, you're up. I met you. You're unmuted. Keep going.
Hi, everybody. Nice to meet you. I live in Switzerland.
Amazing.
It's the first time I talk with everybody, but I have watched some of the VMR. Big fan also.
That's so cool. Welcome, Ariel. Welcome. How do you pronounce your name? Stefan or Stephen, or how do you say it?
Stefan.
Stefan. Wonderful. And Hans is curious, where in Switzerland?
I live in Geneva.
In Geneva.
I'm a third-year internal medicine resident.
Cool. Awesome.
My English is not that good, but
I disagree. I disagree. It's pretty good. I'm sure it feels hard, but it's pretty good. Okay. So I have a story to tell you about a patient. And this is me working in the emergency room when I was an intern. And all we knew was the patient was fine when he was at work. He went into the break room where there are some supplies and then never came back out. But 2 or 3 hours later, somebody knocked on the door and saw that he was on the floor and unresponsive. Okay. So we're essentially have an unresponsive young male, and that's all we know. Stephen Hoffman, maybe I can ask you to share your screen so we can see what you're scribing. And if not, I'll let you know. But yes, Rafa, tell us more. What do you want to do?
The first thing I would do like he's unresponsive, right? I
Yes.
think the first thing I would do is try to check for the pulse, and if there's no pulse, call for help, and
Okay.
start doing compressions.
Amazing. Okay. Let's pretend that he has no pulse. So you're there in that scenario. You're gonna call for help. Absolutely. You're gonna start doing chest compressions. Do you have a sense of what a good rate of chest compressions is?
I'm sorry, could you repeat the question?
And do you have a sense of what a good speed is for the?
Oh, there's this song "Staying Alive," right? You sing?
Nice. Yes, Ariel. Ariel, can I ask you a question? What happens when dogs don't have a pulse? What are you supposed to do then? I'm really curious now.
Very similar to what you
Yeah.
do with
Okay.
humans. Yeah.
Well, really good to know. I hope it never comes in handy, but now I will thank you if it does. Yeah. So, the most important thing I would say before you begin to do compressions is to make sure that you're not compressing into a soft surface. So compressions are only effective when the chest is compressed. So you could hypothetically, if he was lying down if he fell and he was on like a cushion or something, if you just do chest compressions, you're not doing anything. So I have a mental checklist of call for help, start compressions, ideally simultaneously. You can scream and do compressions at the same time, but make sure that you are compressing against a hard surface. Because if you're compressing against anything but a hard surface, it's not going to be very effective. Okay, the good news is he actually has a pulse. And the way you know he has a pulse is even before you check, you see that he's breathing. And breathing implies perfusion, which may be erratic, but if you see that he's breathing, the odds of you doing chest compressions are very low, not zero. So you notice the symmetric chest rise, and then he's felt to have a pulse, but completely unresponsive. Okay, I kind of missed the chat a little bit, so let's start afresh. What are you doing now? Oh, beautiful, Deborah. Tell us more. Exactly right.
We have the rule of 5S for loss of consciousness, that is stroke, syncope, sugar, stroke, syncope, sugar, sleepiness. Can someone help me with the last one?
Oh, no, so say what you know again. Say it again.
Stroke.
Oh, yeah.
Syncope.
Syncope, perfect.
Sugar. Sleepy, and I lost. And Ravi said substance.
Yeah, Ravi, do you want to say it out loud?
Yeah, you mentioned it started off with 4 S's, remember? So stroke, syncope, sugar, seizure. Then you mentioned a few weeks ago sleepiness. So I've had patients like that. You go in and they're so asleep, it's sort of like deep sleep of the aged. And I would turn to my intern and say, guess what? This patient's probably sleeping, but let's do the workup. So sort of like narcolepsy, what Rafa is mentioning. And just this past Monday, substance was added to that too. So substance could be opioid or other intoxicants that can use that. So now we're up to 6 S's.
I love it. I hope, who knows, by the end of VMR, we'll be up to like 15 S's knowing us. But yes, so we've hit 6 now. Amazing. Okay, perfect. Okay, let me just share it. You never really know when somebody is found down, which is if somebody has no pulse, then you're in a different schema, right? But if somebody is found down, you have to step back and ask yourself, what is the cause and what is the consequence? Okay. And the syndrome of found down carries with it a coat that makes it hard to recognize what is actually the problem. And that coat is accumulating the consequences of falling and not moving. So we learned that my dearest friend, Deborah, drinks at least 5 liters a day, right? And if you are found down, you can't drink any liters a day. And so you might get hypernatremia, AKI, rhabdo. And if you fall, you might have broken something, or the reason that you were found down is because you slipped, had no problems, and you have a subdural. So found down is very hard. I encourage you, when you're taking care of these patients, to stratify them into what's the cause and what's the consequence. And the cause actually can be filtered down by how responsive they are. And you immediately went here, okay? Because you immediately went here, sorry, he's unresponsive. And you checked a pulse, it's good, so it's not shock. And then you asked the differential diagnosis of severe acute AMS, and that's the 6 S's. But the learning here is when you're seeing this patient, you have to make sure that you dig through the coat of camouflage that has emerged as a result of the accumulation of the consequences of the cause. So for example, what mistake can you make? CT scan when he gets to the hospital, subdural, full stop. He missed a seizure, missed syncope. And I've seen that happen. So always, whatever you find, after you find something, whatever it is, file it, cause or consequence. And sometimes you don't know. And if you don't know, assume it's a consequence because you don't want to miss the cause. Any questions about any of that? Sorry, I closed the chat accidentally. Okay. All right, let me tell you more. So he's not really responsive, but he's breathing. He has a very strong pulse. You're the EMS now. What do you want to do? He's right there in front of you. He's not responsive, but he has a good pulse and he's breathing. What are we going to do if we're the person right there? Okay, finger stick glucose. If you don't have any tools, what would you do for that issue? So if you have any access to anything sugary, and if the patient can drink, great. If they can't drink, you can put sugar glucose paste and many things around their lips and gums and rely on sublingual absorption. So that also is a trick. But say you have some tools, you get a finger stick glucose. What else would you consider if you're, what do you think EMS considers in these scenarios? Beautiful. Angelita, do you have the ability to unmute and share this thoughts out loud so people on YouTube can hear them? Oh, no worries at all. So Angelita is saying, what's the pulse? Or is there any deficit at all in terms of the blood pressure, I assume, which is awesome. Alex is reminding us to consider Narcan. Alex, do you want to tell us how you decide? Like, say in that moment, what would push you towards giving it?
My guess is they would probably like check pupils. They would look at the respiratory rate.
Absolutely. Yeah, I think the combination of respiratory rate and pupils and any clues at the scene. So if you see a pill of oxycodone at the scene or whatnot, I think those would really be very helpful. Beautiful. So I think the things that are available to you are getting a set of vital signs and empiric therapy. And empiric therapy is really glucose, Narcan, and then one other thing. When somebody's completely unresponsive, what do you think EMS might need to do to protect them from a consequence, not a cause, to protect them from a, yeah, beautiful. Ariel, do you want to say that out loud?
Protect the airway. We do that to veterinary students, to veterinary patients a lot.
Yeah.
They can aspirate when they're not responsive.
100%. Yeah, I think the lack of pharyngeal tone and reflexes are a big deal, and patients can have devastating consequences of aspiration of their salivary secretions if you don't protect their airway. So his vital signs were actually normal, but he was comatose, so they intubated him in the field. His finger stick glucose was normal, and he was brought to the emergency room. Oh, beautiful, Ravi. I was actually just going to get to that, but I think you should tell us now. So you're walking to see him now in the emergency room, and you have good vital signs. He's intubated and he's doing well on the vent. He is satting well, and his end tidal CO2 is normal. Ravi, tell us more what you're prioritizing in that moment when you're first seeing him.
Yeah, I've had this experience of a rapid with a patient that's unresponsive, and just, we don't know anything about this patient, whether they're coming from, if they're coming from somewhere and they may have accidentally taken too much of their fentanyl patch dose if they're on such a substance. So definitely doing a survey of the skin, because I've been blindsided by this before. Had a patient, I sort of saw a shimmering little thing on their skin, on their shoulder that was exposed, and then moving to the other side of the room and then finding that was a patch. It was a fentanyl patch. And sometimes the absorption rate increases with diaphoresis, or if you have fever or something like that.
That's a very powerful story. Hopefully it sticks with everybody listening. So powerful. Thank you for sharing it. Angelita, who I know can't unmute, is saying, get more history. So trying to understand what he's doing at the break room. So calling his employers, seeing if he has an identification card on him with a home contact or family contact, that would be a game changer. Okay, let's take a pause and kind of reflect and try to build a schema to help us in these situations in general, but I'm going to take you out of the acute scenario here. So you're sitting having coffee or drinking water. If you're with Shema, you're probably sipping coffee. If you're Deborah, you're probably chugging water. And ask yourself, what disease categories, example being cancer as a category, what disease category cause someone, oh my God, they're making fun of me in the chat, but I'm gonna gloss over it. What disease categories cause someone to walk into a break room and not be able to walk out? Oh, no worries, Angelina, no worries at all. And cheers, Ariel, here's some tea too. Okay, what disease categories cause somebody to walk into a break room and not be able to walk out? Autoimmune disease? Okay, keep making that list. Priyanka, do you mind sharing that thought if you're able to unmute? Oh, no worries. Priyanka is also unable to unmute. She said seizures. Ariel, do you want to unmute and share your thought?
I'm just throwing things out here.
Totally, 100%. Yeah, so you're saying neuro, metabolic, and toxic. I love it. We're going to hit on all of those. That is all absolutely.
Cardiovascular.
Yep. Okay. All right, keep it going. Any other thoughts? Max, superb. Do you want to unmute and share it out loud if you can? Oh, yeah, the trifecta of unable to unmute. No worries at all, Max. No worries at all. Max says cardiovascular disease, PE, MI, aortic dissection. Absolutely beautiful. So if you're like me and have too much time on your hands, you sit and you sip your tea, hanging out with Ariel, and you realize that there's a theme. Everything that was said falls into a theme. Let me show you what that theme is. Things that happen abruptly or suddenly are either acute mechanical diseases or diseases attributable to the effect of a single molecule that acts quickly. So either something mechanical has happened or a dangerous molecule rapidly accumulated in its concentration. Okay. Sorry, my computer has been acting very slow, so I'm just about to pull up the Evernote. Okay, we're ready now. Sorry for the delay. Oh, nice. Y'all, anyone listening on YouTube, one of the reasons you should join live is because there's way too much wisdom in the chat to capture. Angelita's comment about him coughing maybe is incredibly powerful and very, very shrewd. Okay, what happens suddenly? Mechanical issues like an obstruction or rupture. Now, what would those things be? Obstruction of a vessel like ACS or stroke, or obstruction of something else like bowel or even the eye. These are things that happen abruptly. The other mechanical thing is the exact opposite. It's something suddenly rupturing, again, like a vessel, which Max mentioned, or something else. So mechanical disease, either obstruction or rupture. The sudden discharge of electrical activity either in the heart or the brain, the two electrical organs, or the abrupt onset of a specific molecule. In GNR bacteremia, it's lipopolysaccharide, LPS. If you remember from your step 1 days or incoming step 1, this will come up all the time. And Jerick-Herxheimer, again, it's antigens from the specific spirochete, anaphylaxis. Again, it's the mediators from mast cells, histamine, serotonin, skyrocket. Toxins, we mentioned a lot already, and then insulin. So if something happened to somebody quickly, I guarantee you either it's something mechanical, electrical, or a specific molecule rapidly increased in concentration for a variety of reasons. And so that's the question for this patient, is which one of these happened? So let me tell you more, but let me pause for a second to make sure there's nothing in the chat. Electric shock by coffee maker. Okay, I love it. I love it. The chat's on fire today. Thank you, Ariel. Any questions about that? Cool with that? Okay, you'll notice that the theme for these kind of new Saturday style VMRs is a lot of practical and acute stuff, but we also get nerdy. So it's gonna get nerdy, real nerdy. Okay, Stephen, do you want to share the whiteboard again? Sorry for stealing it from you. Yeah, take your time. There's no rush. So you don't have to put in his vital signs. They're all normal. And his exam, essentially, he is not responsive, but has no other abnormalities. The money is in his labs. Okay. So his CBC is completely normal. His sodium is 135. His potassium is 4.5. His chloride is 110. His bicarb is 10. His BUN is 75. And his creatinine is 6.2. His glucose is normal. His calcium is low at 5 with an albumin of 3.8. And his liver enzymes are all normal. You do an ABG prompted by that bicarb, and the ABG shows the following: a pH of 7.18, a PCO2 of 18, a bicarb of 10, and a lactate on that ABG is 11. All right. I told you it's getting nerdy. Now you know how to do things. Now you have to think real hard. So I'm going to pause for 30 seconds, see what thoughts accumulate in the chat, and then we'll nerd out. Hans, you want to tell us how you came to that conclusion about his acid status?
No, actually, I didn't even calculate. I saw the lactate.
Yes.
And that is already leading to a metabolic acidosis. And it must be an anion gap metabolic acidosis, but I cannot yet figure out what's wrong with him because it's low calcium, but normal potassium. So if he has kidney failure, and he probably has a failure with his kidneys, the creatinine is too high. Why is the potassium still fine?
Yeah,
Or relatively fine. I was expecting it to be higher.
I couldn't agree more. You found a situation where the pH is low, so you know it's an acidosis. And the question that you're trying to answer is, what is the culprit? A high a carbon dioxide or a low bicarb? And you see that the bicarb is low, and so it must be a metabolic acidosis. And the next question is the metabolic acidosis simply because of too much chloride? That's called a non-gap acidosis, or is it because of something else? And that's called an anion gap acidosis. And you see that the anion gap is elevated here, so you diagnose him with an anion gap metabolic acidosis. So let's stop there and ask this question. There's many other questions. And as Rafa, do you want to say the point out loud of what you said to finish the thought? What about the CO2?
When you see acidosis, you have to ask yourself, is this due to decreased bicarb or increased CO2? Yeah. So if you see that it's decreased bicarb, you know that it's metabolic in nature. And then you expect the CO2 to be low because you're blowing off your CO2 by hyperventilating, compensating, you know.
Yeah, 100%. You nailed it. So now we have to analyze the causes of an anion gap metabolic acidosis, and we're going to do that. But before we do that, we're going to get so nerdy that I think it's a good idea for us to highlight one or two things that were new for us that we learned. So Shema, I know you're furiously typing away at teaching points, but I'm curious what was most new to you so far of all the things we talked about.
What was also new to me, what actually Hans said, because actually in metabolic acidosis, I always mostly expect a kidney injury, because the kidney is also a very important organ for compensating these. So this would be the most curious thing to me.
100%. Beautiful. Stefan, my friend, all the way in Switzerland. What's been your most new teaching point today so far?
Boy, I don't really have thought about it, but to understand the onion gap, for me, the onion gap, I'm not sure to calculate it that he has an onion gap, because I'm doing the math with me, but
nice. Can I tell you a way to cheat? I'll tell you a way to make it easy. If the chloride is normal, which here it is 110, it has to be an anion gap. Why? Because when there's a non-gap, the chloride is high. So I just look at the chloride, and the chloride is not high. I know it's an anion gap. Because what is acidosis? Acidosis is low bicarb. What is metabolic acidosis? It's low bicarb, right? And because none of us are charged, as a result of the low bicarb, something else has to come and be high. And the simple question of gap versus non-gap is merely saying, what filled the space of the low bicarb? Is it chloride, non-gap, or is it something else? And something else, we get very lazy and we just say anion gap, meaning that it's not chloride. That's all it means. And now you have an expedition to do to find out, well, which one is it? Is it lactate, ketones, uremia, substance? So if you just look at the chloride, and the chloride has not increased to compensate for the drop in bicarb, you know there's a mysterious anion. So that's an easy way to do it. Does that make sense?
Yes, it makes sense. That, I think it's a new thing I learned.
Good, I'm glad to hear that. What about you, Ariel? What did you learn that's new?
I'm just shocked with the turnout, because we don't see, I don't know, AKI presenting as loss of consciousness a lot. So I'm very excited to find out what's happening.
Yes, I love it. Well, let me tell you. So let's build a DDX for what causes an anion gap metabolic acidosis. So what do you all think is the most common cause in the United States of an anion gap metabolic acidosis? Oh, Shema, do you want to share? Go ahead.
Sure. Here, where I come from, we always use the co-small mnemonic for anion gap, metabolic acidosis, K for ketones, U for uremia, S for salicylate, then methanol, ethylene, glycol, uremia, and lactate.
I love it. I love it. That's very helpful. Rafa, you were saying DKA and mentioning ketones is a very common cause. And Stefan's question was really good about calculating the anion gap, because look at all these mnemonics. All these mnemonics are simply different ways of trying to understand what is that other anion that's accumulating now that we've made the determination it's not chloride. The only anion that we always measure is chloride. And if it's not chloride, we have to go figure out which specific one we need to measure. Do we need to measure lactate, ketones? Do we need to measure salicylates, all the other ones, right? That's what we're doing. So this whole thing about anion gap versus non-gap is just lazy. It's just saying, is it chloride or not chloride? Why do we pick out chloride? Why do we single out chloride? Well, because we have it for free. We've never just mentioned a bicarb without the chloride. So it's this approach of non-gap versus gap is not a biological concept or some sort of like natural beauty thing. It's simply a product of what we have testing for. No one has ever ordered a bicarb with a chloride. So it's just a product of how lab tests, how we order tests, not anything else. If we order lactates with these panels every time for the beginning of time, then we wouldn't have this approach. So I really want you to understand an anion gap, a metabolic acidosis is just what anion built up and took the place of bicarb. That's it. What anion built up and took the place of bicarb. One is already there for us to see, chloride. And the rest we have to think about deliberately because we don't routinely, reflexively order them. So that's concept number one. The next concept is the most important concept of this case. You can accumulate these anions that fight bicarb either from endogenous production, so you made it yourself, the patient made it themselves, or they drank it. Okay? So what are the endogenous causes? Ketones, lactate, uremia. Ketones, lactate, uremia. Those are anions that your body can make that replace the bicarb. What can you ingest that replaces the bicarb? Toxic alcohols, salicylates, and some other less common substances. But the focus is always on toxic alcohol and salicylates. Just to say them, but only once. The other substances are chronic Tylenol toxicity, valproic acid, levetiracetam or Keppra in patients with end-stage renal disease. So there's some very rare. Most exogenous are toxic alcohol like methanol, ethylene glycol, propylene glycol, and salicylates. Okay. Any questions about any of that? Let me show it to you visually. Endogenous, lactate ketones, and these are products that accumulate when you have AKI or rhabdo, sulfates and phosphates. The other, toxic alcohol, salicylates, and some other ones. Okay? All right. Now here's a hard question that we should answer before we move on. Can you think of any tests that help you determine if the source of the mysterious anion is endogenous or exogenous. Can you think of anything that will tell you? Yes, Ariel, say it. You nailed it. Can you say it out loud?
Serum osmolarity.
Yeah, and how did you come to that answer?
I was just thinking about like antifreeze ingestion will cause like really high osmol.
Exactly right. So let me explain that. If you are making an endogenous anion like ketones, lactate, or sulfates, you're just replacing your bicarb. It doesn't affect the number of electrolytes in your body. But if you ingest something, you will have an increase in your osms. Okay? So how do we figure that out? We measure the patient's serum osms, and then we calculate what it should be if there's nothing there. So if there's nothing there, we calculate it, and we call that the expected osms, and then we measure it. And if there's a gap more than 10 or 20, you should be suspicious that there's something that shouldn't be there. So let's understand it again. What's the final approach to an anion gap metabolic acidosis? Check serum osms. Normal or no gap, ketones, lactate, uremia. Plus gap, toxic alcohol, salicylate. It's that simple. Really nice job, Ariel. Really, really nice. I love how you're using your understanding to come up with it, which is just the best way, because you're much less likely to forget it if you use your understanding, you know? Okay. Now here's the mistake that happened in this case. So Stephen, you want to pull it up again, and I'll tell you the data. So Hans immediately noticed the lactate and started talking about that lactate. Problem solved, right? You have an anion gap metabolic acidosis, and the lactate is 11. And Hans is shaking his head so vigorously. He's like, no, problem is not solved. And he's 100% right. Now, I'll just leave you with that and give you two more pieces of data. At the same time, the lactate was 11 on the ABG. The lactate is 2 on the blood specimen from the vein. I told you this was an ABG lactate. It was 11. The blood lactate from the serum is 2. The osmolarity gap here, 35, very high. And with this, you have a classic presentation of a disease that people in the chat already diagnosed. But I'm going to let folks think it through here and on YouTube. But there's something we haven't talked about. And the thing we haven't talked about is the hypocalcemia. Very rare, right? Unusual. Maybe for the next minute, let's practice with the chat. What do you think of as common causes of hypocalcemia? Yeah, Max is saying hypoparathyroidism, probably the most common cause. Beautiful. Oh, thank you, Rafa. Ionized calcium is also low. Great question. Hans is saying, and vitamin D. So Max, hypopara and vitamin D. Hans is saying, unless the substance he ingested binds calcium. And with those two lines from everybody, you've nailed the approach to hypocalcemia. Okay, as Shema is saying also, chelation. I'm showing you the schema, one moment. Okay. You all nailed it. It's either hormone deficiency, PTH and vitamin D, as Max said, and then chelation. I'm going to leave this list of chelation here for you to look at and then for you to tell me what the answer is. So I saw that the diagnosis was actually mentioned a while ago. So Hans suspected ethylene glycol toxicity pretty early on. And I think it was pretty alarming to think that he had somehow consumed this and was down for a few hours and got so sick. And it turned out that there was antifreeze in the closet that space was in, and he consumed a large amount of it. And I'll leave it at that in terms of the details of the patient. What do you all want to do? How would you treat him? I'll tell you, you're going to send a ethylene glycol level. The one tool that you have to increase the chances of the diagnosis is to look at the urine. If the urine has calcium oxalate crystals, it further increases the chance of the diagnosis. And a fun fact, the urine in patients with ethylene glycol toxicity fluoresces on a Woods lamp. You know the Woods lamp, the lamp we use to look in the eye for patients? It looks pink on the Woods lamp. Ariel is telling us that in veterinary medicine, they do IV alcohol because fomepizole is so expensive. And Alex and Max are sharing a little bit more about dialysis and fomepizole. Alex, do you want to tell us what you know about fomepizole?
Not all that much. I think that it has a higher binding affinity for alcohol dehydrogenase.
Oh.
So I think it's the toxic byproduct of ethylene glycol metabolism that's really the danger. That's kind of all I know.
That's absolutely superb. I think with that, you were teaching us that ethylene glycol is not the problem. It's the unique combination of us with our enzymes and ethylene glycol that creates a toxic product to us. And if we give ourselves a medicine that eliminates us from the equation and our enzymes, we metabolize ethylene glycol like no problem. It causes inebriation just like ethanol does. So you'll get drunk and have dysarthria and ataxia from it, but then it washes away, leaving no permanent imprint, similar to ethanol. Because of how so he got fomepizole and dialysis, as Max alluded to, and actually did pretty well. Yeah, crazy case, very humbling from residency. I was in the ER at the time, and I want to open up to any questions that we can iron out before I pass the mic to Shema to recap the teaching points.
I have a question.
Yeah, go ahead.
So is the loss of consciousness because of inebriation from?
Correct.
Okay, so it's not from the metabolic acidosis itself.
Exactly right. So, metabolic changes, the only metabolic change in terms of pH that's associated with altered mental status is respiratory acidosis from accumulation of CO2. No other change, respiratory alkalosis, metabolic alkalosis, or metabolic acidosis is directly implicated to confusion. Some people will say that in patients with metabolic alkalosis, they have hypoventilation and they can get confused, but I'd say as a general rule of thumb, the only pH change that causes AMS is respiratory acidosis. That's a really good question. So you might say here that his kidney dysfunction is contributing to his altered mental status. So he might have uremia, but that's possible. The argument against that is it takes a little time for patients to get uremic. So it would be unusual for somebody to get uremic in a few hours, but possible. All right. I was hoping this question comes up. Alex has asked a fantastic question. I would love for you to ask it out loud, Alex, so the folks on YouTube can hear it.
You mentioned before that there was a difference in the lactate level between the vein and the artery.
Yep.
Hadn't had a chance to look it up yet, so I was wondering if you could give us some more insight.
All right, you all ready? This is the key to unlocking this case. all these toxic alcohols have tests that come back at least 2 days later. And so you have to have tools in your armamentarium to suspect them well before that test comes back. The best tool, the serum osm gap, hands down. What are adjunct clues for ethylene glycol specifically? It is a difference between the point of care lactate and the serum lactate. The point of care lactate uses a machine across the United States that confuses the oxalate in ethylene glycol for lactate and accidentally calls it a lactate. So it's an error. There is no lactate, but the machine confuses it and calls it a lactate. So the concept is called a lactate gap, where the lactate on the ABG or VBG, the point of care machine in the ER right there, makes it really high and the serum is low. Let me show you all the other clues for all the other metabolites. Thank you for this awesome question. So, what are other clues? I call them the curious labs. In methanol, your patient, the clues will be that they have basal ganglia lesions. So they might have hemorrhagic basal ganglia lesions and they will have loss of vision. And they have a high creatinine with a normal GFR. Again, an artifact of laboratory testing. How will you know a patient has a high creatinine and a normal GFR? If you have access to it, you can measure a cystatin C. A cystatin C is a great biomarker for GFR, and you'll see a high creatinine, but a normal cystatin C. What about calcium? What about ethylene glycol? So this is methanol. What about ethylene glycol? AKI, hypocalcemia, and this hyponicure lactate with a normal lab lactate. Okay. Awesome question. Thank you for asking. All right, time to go home with Shema.
Sure. So, hi, everyone. So thank you so much for this great case, Ravi. I learned so much. I always have a big phobia, but I know Sammy will really like this case. So coming to this case, so we had a patient with altered mental status, but he was still having a pulse, so he was still alive. And as an emergency, we would perform chest compression, always think to make it on a hard surface. And if you want to know how the velocity is, keep the songs like Staying Alive by the Bee Gees or Highway to Hell by, I think it was Acidosis in mind. And then we're talking about the 6 S of loss of consciousness. We were always considering 5, but it's already 6, like sugar, stroke, syncope, sleepiness, like narcolepsy, seizure, and substance abuse. And then the thing is, if you find a person down, always think of the causes, like if he's unresponsive, consider shock or severe altered mental status. And if he's responsive, consider altered mental status and fall, and also always consider the consequence. And then if you have altered mental status together with a strong pulse, as you know, we perform first aid, where's this ABCDE schema, and then check pupils, do finger stick, give glucose. And if you suspect an opioid intoxication, give naloxone, and also always think of airway protection in recovery position due to high risk of aspiration. And also check the skin for patches like fentanyl patches. And then the great question came in, like, what disease categories lead to going to a break room, not being able to walk out? Like, think of seizure, stroke, metabolic, toxins, and cardiovascular reasons like pulmonary embolism, cardiovascular, myocardial infarction, dissection. And then then we had the categories of acute mechanical things like obstruction or rupture, electrical causes or diseases that are attributable to a single dangerous molecule. And then we were talking about anion gap metabolic acidosis, and this is suspicious if we have a decreased bicarb. And then the reasons for an anion gap metabolic acidosis, I wrote down the Kussmaul mnemonic, you can read there. And then We were also trying to divide between non-anion gap and anion gap metabolic acidosis. In non-anion gap, the bicarb is being replaced by chloride, and in the anion gap, we have the Kussmaul. And also for the replacement of bicarb in anion gap metabolic acidosis, we have endogenous causes, and the most common are ketones, lactate, uremia, and exogenous causes are toxic alcohols, salicylate, valproate, Kepra, so levetiracetam, and then we also have an easy approach to anion gap metabolic acidosis. So check the serum osmolarity gaps, because a high gap suggests substances with high osmolarity like toxic alcohols. And then we had hypocalcemia in these cases, and the most common cause are hypothyroidism, low vitamin D, and chelates, I don't know how to pronounce it, like phosphorus, citrate, massive transfusions, or the ingestion of ethylene glycol, like in this case. And what I also learned new is that ethylene glycol leads to a pink urine in wood slide, and we see calcium oxalate crystals in the urine sediment. And the antidote is fomepizole or ethanol. And what we also learned is about the high point of care lactate with normal serum lactate and ethylene glycol intoxication, because the machines aren't that smart. Thank you so much. Hope to see you again soon.
Oh gosh, Shema, that was amazing. Absolutely superb recap. Thank you all, and hope to see you next time. Take care.